Hello, and welcome to the Facial Paralysis and Bell's Palsy Foundation presents. I'm Lisa McKinley, Director of the Foundation, and I'm assisted today by our Portland, Oregon support group leader, Barbara Pasternacki. Thanks to everyone for logging in today, and please feel free to submit your questions at any time during the presentation by using the questions box located on the control panel on the right side of your screen. The questions will be answered at the end of Jackie's presentation as time allows. I would now like to introduce our speaker today, Jackie Diels. Jackie is a leading authority on facial neuromuscular retraining, a non-surgical therapeutic approach to the treatment of facial paralysis, paresis, and synkinesis. She received her degree in occupational therapy at the University of Wisconsin in 1985. She began her work in facial NMR there at the Neuromuscular Retraining Clinic in 1986, and she has dedicated her practice exclusively to the treatment of facial paralysis ever since. Jackie has authored book chapters and articles and trains other therapists, both in the U.S. and internationally. She currently serves on several medical advisory boards, including that of our foundation. We are honored to have Jackie with us today, and I will now turn the webinar over to her.
Thanks very much, Lisa. I appreciate being here, and I appreciate everybody tuning into this webinar today to listen to the information about this extremely important subject. So as Lisa mentioned, I'm primarily at the University of Wisconsin, started there in 1986. So I have been there for quite a while and have devoted my entire practice to the treatment of non-surgical facial paralysis. The program was originally established in 1983 by my mentors, Dr. Paul Buccinator and Richard Ballier. It's devoted specifically to the treatment of peripheral facial nerve disorders. So a peripheral facial nerve disorder is a facial paralysis that's caused by injury to the facial nerve directly, as opposed to an injury to the brain, such as a stroke. So we don't see patients who've had strokes in this program. Since 1986, we've treated approximately 15,000 patients with diagnoses including operative trauma, vestibular schwannomas, meningioma, and other skull-based tumors, viral facial paralysis, and that would include Bell's palsy or herpes zoster oticus, which is shingles that can affect the facial nerve. We see those patients after 3 months have passed, because 85% of people who get Bell's palsy will recover within 3 months without any intervention at all. We see people who've had trauma to the temporal bone inside the skull where the facial nerve travels, and auto accidents, motorcycle accidents, things of that nature can cause injury in that part of the brain. We see people with Lyme disease, and that can impact the facial nerve. People who have congenital facial paralysis, so who are born with facial paralysis. And then we see an entirely different segment of people who have had an anastomosis, which is a facial nerve graft, or surgical reanimation procedures. Cicero said the face is the image of the soul. It's how we portray who we are inside. It's the way we communicate with other people. It is how we are identified as unique individuals in this world. I'd like to introduce you to one of my patients. This is Susan, and this picture was taken 3 months before a right acoustic neuroma left her with a complete right facial paralysis. And I can't see you in the audience tonight, but I know your reaction to this slide, and this is a devastating thing. The emotional consequences of facial paralysis cannot be overstated. My presentation tonight is not about that, but that is a part of the retraining process, is dealing with some of the emotional aspects, and all of you there know much better than I do the extent the extent of emotional difficulty that this brings into your life. We will talk about Susan in a little while again, but what I want to point out here to you is that you can see on the right side of her face that there's absolutely no expression. This is the same person that you see over here. On the picture on the left here, she was out with her buddies having a drink after work, and then 3 months later, this is what happened. She has no expression on the right side of her face. Her eye is unable to close, and so she has stitches, this is called a tarsorrhaphy, on the inside corner and the outside corner of her eye in order to protect her eye from exposure. So here are some ground rules. I call this face facts of non-surgical facial rehabilitation. These are things that we all know. We all know them, but we never think about them on a conscious level because, by and large, nothing ever happens to our face. We don't really think about how we move it until somebody puts a camera in front of us and says, okay, smile. So here are some things to think about as we get started. Voluntary facial movement is not the same as spontaneous movement. When someone asks you to smile on purpose, it's not the same as when you see an old friend that you haven't seen in a while and you smile. Facial movement is mostly unconscious, and it's unlearned. Most of the time, we're unaware of how our face really moves. This next one is extremely important, especially for the rehab process. Normal facial movement is small. It's precise, and it's effortless. It's effortless. And so when people come into therapy and they're trying to move their face as big and hard as they possibly can, that is not even a normal way that we move our face. And so I'll be talking quite a bit about that in a little while. The training process requires engagement. People have to think about what they're doing. It requires effort, time, and consistency of practice, just like learning any other type of fine motor skill. Most therapists are not trained in facial, nerve, and muscle anatomy, physiology, or rehabilitation techniques, and so they typically will use techniques that are very effective on other parts of the body when they see someone with facial paralysis. And so, as we'll see in a little while, the facial nerve and muscle system is different than other muscles in the body, and techniques that therapists learn for treating those other things do not apply and are not effective in treating facial paralysis. The key is in education. I talk about training versus treatment because the program is not really hands-on where we go in and manipulate the face, but it's rather training people how to identify what muscles move what parts of the face. And because facial movement is mostly unconscious, we never think about those things. So in the training process, we think about those things. We work with functional movement patterns rather than maximum effort movements. I can smile nicely and looking at you all here in the camera, but I never would smile to maximum effort in a normal situation. So I've been talking to you now for about 5 minutes, and I haven't ever said, well, it's so nice that you could all join me on the webinar. We don't move our face in that manner. It's subtle. It's small. It's very, very delicate. And most importantly, it is extremely precise. Engagement in the process is essential. This program is not like going to a gym and doing 10 or 15 reps of a movement pattern. You have to really think about which muscle am I trying to flex? Which muscle am I trying to relax? How do I coordinate the two sides? How do I coordinate all the muscles just on one side of the face? And there's no time limit to when retraining can begin. And you see here I have that in parentheses, synkinesis. So many of you I know what synkinesis is, and I'll be talking about that quite a bit in a little while. But for those of you who have abnormal movement, so for example, when you smile, your eye closes, or when you pucker, your eye closes, there's no time limit to when we can begin the retraining process, because in those cases we're working on recoordinating movements, not trying to resurrect something that's a dead movement. I'd like to go through the anatomy of the face. I think it really helps people to know which muscles do what in the face. We're all familiar with how the bicep works, for example, or how the fingers work. All we do with our hand, with our fingers, is we flex our fingers. They only move in one direction. Our face moves in many, many different directions. And so I'd like to go through that with everybody right now. But first, let me talk about the model. Now, this is very interesting. So here we talk about 3 parts of the facial neuromuscular system. The generator, this is the brain. This is where the signals emanate from. So the brain sends the signal to the facial nerve, which is the wire here that connects the brain to the muscles. The muscles would be the bulb. So we've got the brain sending the signal, or the generator inside the wall, sending the electrical signal through the wire to the bulb, so the bulb goes on when you turn on the lamp. In facial paralysis, peripheral nerve facial paralysis, it is the wire, the connection between the brain and the muscles, that gets crimped or cut or compressed, and so it's the wire that actually stops sending the electrical signal to the muscles or to the bulb. So for example, if I cut this wire right here, how many times would I have to flip the switch on the bulb to get it to go on? Right? You could flip it till the cows come home, and that bulb will never turn on until the wire is repaired or the compression is removed from the wire. This is going to be important as we talk about the rehab process. So onto the muscles. Oh, see, I should know my slides better. So here's the brain, the generator. Here's the brain. And this is the part of the brain that's responsible for moving the face. And what's very interesting to see is that in this model, you can see how much space the face actually takes up on this movement part of the brain. It takes a very large surface area. The hand takes less, the arm takes less, the shoulder takes less. Here's the torso, here's the little butt, here's the leg, and here's the foot. By far, there's more brain space devoted to facial movement than there is to any other movement of the body. And that speaks to how complex it is. The cranial nerves are the wires that connect the brain to different body parts. So there are 12 pairs of wires. And this picture here is a picture of the underside of the brain. So as if you were going to take your brain outside of your head and flop it down, upside down on a table and take a look at it. I do not recommend that, however. So the nerves that we're interested here are the facial nerves, and they're the little green ones that you see right here. And they leave the brainstem at this point, and then they move through a bony canal in the skull itself, and they come out behind the nerve. Behind the ear. And this is where the nerve comes out, and then it spreads out. And there are several different parts of the facial nerve. What we have in yellow here are the nerves that go to the muscles of facial expression. The orange go to the tear glands and the salivary glands, and many of you I know have dry eye or excessively wet eyes and some dryness in your mouth. The green part of the nerve here goes to the taste buds, and I know many of you have difficulty with taste or an abnormal taste in your mouth. and then the blue goes to ear sensation, or some of you have what's called hyperacusis, where you're very, very sensitive to loud noises, especially right after the onset of Bell's palsy. And that's because a little tiny muscle here is out of commission, and that muscle typically dampens the sounds that come in to the ear. From there, in the muscles of facial expression, now one nerve that goes to the muscles of facial expression has between 6,000 and 7,000 individual nerve fibers. And so this is, it's hard to fathom how tiny and how delicate these little nerves are. And they're very susceptible to damage, either from compression or from surgical manipulation or from a tumor that's growing around them. But you can see how they all spread out and go from the main nerve. They branch and branch and branch and go to the different muscles of facial expression. The muscles of facial expression can be thought of as the bulb. And so the nerve has to be intact, going to the muscles of facial expression in order for the muscles to work. If the nerve is not intact, or if it's compressed, for example, in the early stages of Bell's palsy, the signal cannot be transmitted to the muscles. And no matter how hard you flip the switch on that bulb, the light bulb will not go on. And so exercises that many therapists might give early on, smile as hard as you can, pucker as hard as you can, will not work because there's no nerve signal coming through the facial nerve, the wire, to the muscles. The facial nerve innervates a total of 23 pairs of muscles and then the mouth muscle. Now, let's go through what they all do. As you can see from this diagram, let me go back for a second. As you can see from this diagram, each muscle has an arrow that points in a specific direction. That arrow points in the direction that the muscle flexes and the skin moves when that muscle gets the signal to flex. So, for example, they're fairly self-explanatory. This is the frontalis muscle. It's the one that brings the eyebrows up. You can see the arrow points up. When this muscle flexes, the skin of the forehead raises up and the eyebrows raise up. These muscles are located just under the surface of the skin. And here's an interesting concept. These are the only muscles in the body that actually move only skin. All of the other muscles, skeletal muscles, move bones around joints. But for example, if I hold my arm up, there's no way for my brain to tell this part of my arm skin to move by itself, right? But the facial muscles move the skin of the face. They don't move bones around joints, they don't lift heavy objects, and they don't propel us through space. They simply move skin. You don't need a lot of strength just to move skin. All right, frontalis. Eyebrows up. And everybody can practice these kind of along with, now these are not exercises, but you can try them just to see. If you have facial paralysis on one side, you'll notice that it moves very well on one side and not on the other. If you have synkinesis, you might notice that you're getting movement in another part of your face along with this attempt to raise your brows. Eyebrows up. There's the frontalis muscle. The corrugator muscle brings the eyebrows down and together toward the bridge of your nose. Each muscle has its very own specific job and does only one thing. This is the Orbicularis oculi. This muscle is a sphincter muscle. A sphincter muscle closes around an opening. The Orbicularis oculi closes the eye, and you can see it goes all the way around the eye. And so here's soft, gentle closure, and then a tight closure. And here's one of my patients who is having difficulty closing her eye on the affected side. What you see here is that the eyeball actually rolls up and goes underneath the lid. This is called the Bell's phenomenon, and it's a mechanism by which the body protects the eyeball from drying out. She thinks her eye is closed, by the way, because the pupil is up under the lid, the lights go out, and she can't see anything. This group of muscles is called the levators, and you can see the arrows point up here. And these muscles are responsible for raising the upper lip. They show the teeth. They create this crease right here that's called the nasolabial fold. Now this is one of the most misunderstood, believe it or not, muscles of the face. And this is how we smile. So we all think that we smile with our mouth. But in reality, we smile with our cheeks. And let me do a little demonstration for you. So right now you can't see my mouth at all. Am I smiling or not? How about now? And how about now? Can you see how the cheek balls raise up when you smile? The muscles that create the smile are located right here. When they flex, they draw the corners of the mouth up. So here on the diagram, it seems as though they stop right here, but in reality, they come down and they attach right at the corner of the mouth. When they flex here, they raise the corner of the mouth up. The mouth just goes along for the ride, but the smile activates from here. And that's a very important thing to know for most people, because I have people who come into retraining all of the time trying to smile with their mouth and doing all sorts of things and not getting motion the way that they should. Just by telling the brain to flex from the cheek instead of the mouth, you can change the way the brain learns how to activate the smile. And here's a closed mouth and an open mouth smile. This muscle is the risorius. It pulls the corner of the mouth back like a smirk. There you go. Orbicularis oris is also a sphincter muscle. It's the only muscle that pulls in toward the center of the face. It does three distinctly different things. It presses, this is called lip compression. It contracts, pulls in over your teeth, and it protrudes, kind of like a whistle. The composite of this is the pucker. This is the Depressor Anguli Oris. It's located at the corners of the mouth. You can see the arrow pulls down. This muscle pulls the corners of the mouth down. What do you think might happen if you were trying to flex the smile muscle and the Depressor Anguli Oris muscle at the same time? Which way would the corner of the mouth go? These are things to think about. This one is Depressor Labii Inferioris. This muscle is responsible for pulling the lower lip down to show the lower teeth. This muscle is Mentalis. You might notice that the arrow goes up on this muscle. This muscle pushes the bottom of the chin up. And for those of you who have dimples in your chin, who have synkinesis or abnormal movement, if you've ever noticed dimples in your chin, it's a very common area to get synkinesis, and this mentalis muscle becomes quite hyperactive. This muscle is called Buccinator. Now the Buccinator muscle is not necessarily an expressive muscle, but is more an accessory chewing muscle that helps us move the food from one side of our mouth to the other. It's located deep inside the cheek, and when it flexes, it pulls the inside of the cheek tight against the teeth. If this muscle is contracted, especially if it's contracted tightly, it makes it very difficult to move any of the other muscles because it locks the inside of the cheek in place. Those of you who are flute players might recognize this. This is the muscle that creates the embouchure when you're playing the flute. This is the Platysma muscle. Now many of you are familiar with this probably. What this muscle is located mostly on the neck, but it is a facial nerve muscle, and you can see that the arrow points down on this muscle. When this muscle flexes, it draws the corners of the mouth down and wrinkles the skin of the neck, creating these cords. So this muscle becomes quite overactive in cases of aberrant nerve regeneration after healing, after Bell's palsy or acoustic neuroma surgery. And many people get a lot of tightness in this muscle. Physiologically, facial muscles are different than skeletal muscles. And these are some of the things that therapists may or may not be familiar with, but the important things, I think, for people on the webinar today is that facial muscles are very resistant to fatigue, degeneration, and atrophy. And so in the months that it takes for the nerve to heal after an acoustic neuroma or Bell's palsy, I know a lot of people are worried about those muscles becoming atrophied, but they don't. They don't. They have very small motor units. It gives them very, very fine control. So each muscle you can have very, very fine, discrete control of how it moves. And another very important and different thing about the face is that it receives emotional signals from the brain as well as voluntary signals. If I want to flex my wrist, happy or sad, it looks the same. But of course, everything changes based on emotion in our faces. There are 4 main categories of people that I see in the clinic. People with flaccid paralysis. So these are people who have no recovery yet on the affected side of the face. People with paresis. So these are people who are just starting to get recovery, but it's not quite back yet. Their tone is improving, but they don't have great motion yet. The majority of people I see are people who have synkinesis and mass action, which is abnormal movement that occurs as the nerve heals and sometimes develops wrong connections. And then I also see people after surgical reanimation or reconstruction. Most patients who have delayed recovery, either after Bell's palsy, if it's been 3 months or longer, or acoustic neuroma surgery, will follow this sequence. So this is one of my patients, and here she had an acoustic neuroma surgery on her right side. So here, this is 10 days after her surgery. Her husband took these photos for her. This is 10 days, 2 months. You can see it's starting to look a little bit better. 4 months, wow, her smile is looking quite good. Not quite as robust, but very good activity coming back at 4 months. At 6 months, things are looking pretty good. And then at 15 months, what happened? So I got a call from her at 14 months out saying, Jackie, I was getting better and better and better, and now I'm getting worse. So what happened in the course of this gal's recovery? Because what people tend to think is that from this point on, it regressed. But if you look closely, she actually has more cheek ball here, which indicates that the smile muscle is working. But look at what else is happening here. Can you see that there is this contraction of the neck muscle at the same time, the platysma? So now what she's got is the development of synkinesis, where this platysma muscle is pulling down at the corner of her mouth at the same time as her cheek is pulling up. So there's a tug of war going on. The interpretation of facial dysfunction is absolutely critical, and this is where I think most people, therapists, even doctors, aren't quite getting it right. So when you first look at these pictures, it looks like they have the same thing, correct? So we see that the right corner of the mouth is down on this gentleman and it's down on this lady as well. But if you look closely, watch what happens. If we take away the neck and you just look at the cheek ball itself, you can see that this gentleman has no activation of his cheek ball. So his smile muscle isn't back and it's not working. But this gal, look at this. Ton of cheek ball activity. Ton of cheek. And if you look even more closely, you see his eyebrow is way down here and her eyebrow on her affected side is way up. So why is it then that the corner of the mouth doesn't go up on this lady? On this gentleman, it's pretty self-explanatory. There's no activity in the cheek. So let's look further. If we cover up the cheek now and we just look at the neck and the lower part of the face, you can see that this lady has a great deal of contraction in her platysma muscle. And so as she's trying to pull the smile up from the top, the platysma is contracting simultaneously. And I'd like to demonstrate that for you here today. So I can have the best, I'm going to do it on this side, I can have the best smile in the world, but if I flex my platysma at the same time, watch what happens. Now, my smile is still good, but look what happens at the corner of my mouth and in my lower lip. The answer to this riddle is not to smile bigger. It's not to smile harder, but to get rid of the downward pull. Because the harder I try to get out of this situation, the harder this pulls down. And I know a lot of you out there are nodding your head right now because this is what you feel. So I'll show it to you in real time. So good smile. I'm going to develop my synkinesis here. And this is just one area. You can have synkinesis all over your face. And now, to get out of the situation, I'm going to release my tension here. Watch. It's going to take me a moment. So nothing changed here. This remains stable. But what I changed was I suppressed, I relaxed the synkinetic or the abnormally contracting areas. And I hope that was clear here on the webinar. Here are the same two people, and now I'm having them pucker. And you can see that this gentleman has really no tone in the lip. The lip is very thin. It's almost non-existent. And the mouth pulls toward his left side, which is his unaffected side. Now this lady, you can see she has very good tone in her lips. And if you imagine removing her lips from her face, you can see that they're almost completely round. But her mouth is pulling toward her right side, which is her affected side. The mouth will always pull toward the stronger side. Now, the stronger side is not always the unaffected side. In cases of synkinesis or abnormal nerve regeneration, the stronger side can actually be the affected side because there's too much activity in muscles that shouldn't be flexing. So in training, patients are seen post-acutely, and that means months after the initial onset of whatever caused the paralysis, whether it's Bell's palsy, acoustic neuroma, or trauma. We wait until there's some spontaneous recovery to occur so we have something to work with. And the nerve heals in its own time, usually at the rate of about 1 millimeter a day or 1 inch a month. We know then that the recovery is due to new learning versus spontaneous recovery when we see people years and years out. We focus on coordination versus strengthening, on precision versus mass movement. We work intensively in the clinic, periodically, so people come in for an intensive evaluation and training session, and they come in periodically. So it's not the kind of program where people come in once or twice a week, and this is done on an determined on an individual basis, and then they go home and practice their program daily at home. electrical stimulation is never a part of the treatment program. It's not used in facial retraining, and some of you out there may have had electrical stimulation. It has not been found to be effective. It can interfere with the regeneration of the nerve. It reinforces abnormal movement patterns. It never trains functional or expressive movements. And in people who have had a lot of electrical stimulation, we see that they have more mass action and synkinesis than those who don't. People have to be motivated to participate in the program, have good cognition, and have either an intact nerve supply, or if the nerve has been cut or sacrificed during surgery, they have to have a nerve graft in order to participate in the program. If the nerve has been cut and not repaired, there isn't anything that the rehab can do to improve the function. There is a very defined protocol that we go through with the intake and evaluation. As people come into the clinic for the first time, we videotape, we photograph. There are clinical tools and questionnaires that we use. We use surface EMG biofeedback with some people, and then we focus on the development of the home program because that's what people will be doing after they leave the clinic and they work on their own at home. For flaccid paralysis, the most important thing is protecting the eye. Make sure the eye is protected and that you're following the instructions of your ophthalmologist. I highly recommend being connected to an ophthalmologist just to make sure the eye is healthy, because in many cases, especially early on, it doesn't close and it doesn't produce tears. Here's a gal 8 months after acoustic neuroma resection, and this, you can see that this is the picture of her before instruction and the picture after instruction. So there are some good techniques that we use to train improved eye closure. We recommend gentle stroking of the face to promote sensory awareness, and it doesn't stimulate the muscles or nerves in any way, but what it does is it keeps your brain connected to that side of your face, because the face, if it's not moving, isn't giving the normal signals to the brain that it usually does. That here, I'm moving. So we use the fingers just to maintain that connection with the brain. Let it heal. Early on, let it heal. If there's no innervation and no movement at the beginning, don't exercise it. Exercising it doesn't help it. That would be like flipping the lights, trying to flip the light switch on harder and harder, even if that wire is cut. Exercising early on actually can have the effect of creating more movement on the unaffected side, because that's the only side that's being exercised. So I just tell people, let it heal. Just like a bone, a broken bone in a cast has to heal, the facial nerve also has to go through a healing phase before we can work with it. For people who have a delayed recovery, and for Bell's palsy it would be after 3 months, for acoustic neuroma it would be somewhere between 10 to 12 months. We focus on symmetry of movement. We work on very small, precise movements using only the muscles that are required for that particular expression. And EMG biofeedback is used for evaluation and training in some cases. And then late, if there's no recovery, then we can discuss surgical reanimation procedures. But that is very, very far late in the treatment that I do with people. So here's this gentleman who had Bell's palsy in September of '02. This is his initial evaluation, and this is a couple of months later. And so when I first saw him, he was already 2 months out, and this is 4 months out, and here he is in May. And I would just love to sit here and tell you that the result he got, which is a beautiful result, is because of facial retraining, but it isn't. This is spontaneous recovery. It's a little bit on the late side, but he did very well, and I followed him in the clinic just a few times, but he did recover spontaneously. Here's a gal who has paresis. Her tone is beginning to improve. She's beginning to get movement. She's getting better symmetry, and she does not have synkinesis yet. Many people who have paresis and delayed recovery will develop synkinesis. And this is her first evaluation in the clinic, which is just over 2 years after her acoustic neuroma. And she came from a far distance and was in the clinic for 3 days. And this was her initial evaluation, and here she is on day number 3. And this looks like it's quite a miraculous recovery, but really it isn't. What I was able to do with this patient was to help her find her muscles. They were there. They didn't need to be strengthened, but her brain needed to find the correct address of the muscle, if that makes any sense. So that's what we did. And just in learning how the muscles work, where they are located in the face, and how they activate compared to her unaffected side, she was able to have this kind of a response, which is really a great response. Synkinesis, I know many of you out there have this, is an abnormal synchronization of facial movement where muscles other than those intended contract together. Synkinesis causes facial distortion. It's often thought of as non-motion, but it's non-motion the way two people playing a tug of war is non-motion. You've got pulling on one side, pulling on the other side. That kind of cancels each other out. It's not weakness, however. You can see here there are competing forces around the mouth. So for example, if someone smiles, remember we talked about these two muscles are the smile muscles. They pull the corner of the mouth up. Well, what if when these muscles are pulling, this one is pulling? Which way does the corner of the mouth then go? What if this one is pulling? Which way does the corner of the mouth then go? And so we work to isolate each muscle and suppress the muscles or inhibit the action of the muscles that should be quiet during a particular facial expression, whichever one we happen to be working on. There are two issues with synkinesis. One is increased muscle tone, and that causes a contracture and a tightness and spasm of the face. And many of you may find that your eye is a little bit small. That's because the muscle around the eye is a little bit too contracted. You may find that this crease is deep. That's because the muscle that pulls up, that creates the crease, is flexed when it should be quiet, and etc. For those people who have increased muscle tone, which I think is most people who have synkinesis, we do soft tissue mobilization techniques, stretching, massage, and heat. But by and large, the biggest chunk of what we do is work on recoordinating the muscles so that only the correct muscles are flexing. And we call it inhibition of antagonistic groups. So an antagonist is a muscle that's pulling in the wrong direction. So for example, here with Pat, we can see that she's puckering her lips. She actually, if you look at the lip itself, she has a good pucker. But what's happening on this side of her face? You can see that her cheek is pulling, her eye is closing, the corner of her mouth is pulling, and her platysma is pulling. And so we talk about isolated muscle contractions. So this is kind of, Pat's face in this picture is kind of like going to the symphony and hearing all of the muscles playing at, hearing all of the instruments play at the exact same time. If the violin has the solo, the horns don't play. If the pucker has the solo, the smile muscle, the eye muscle, the Buccinator muscle, and the platysma have to learn to be quiet. And in that way, the smile muscle will be able to do the job that it's intended to do. Precision versus power. We don't need a lot of power in the face, as I talked about before. And if I go back to this picture of Pat, you can see if you kind of cover this slide up with your hand, if you cover up the left side of her face, she's got a ton of power here, but she doesn't have good coordination. She doesn't have isolated movement. So we talk about precision of movement, a meticulous coordination of the muscles. The goal with synkinesis is not to strengthen the muscles, but to strengthen the brain's ability to access them accurately, to find the address of the muscles. I'm gonna take a few more minutes here, and hopefully we'll have time for a few questions at the end. So here we go. As I mentioned, the focus is on inhibiting the abnormal hyperactivity rather than strengthening the muscles. In order to do that, movements are done very slow, they're very small, and they're very focused, mentally focused, intentional movements. And here she is, and you can see this is 1 year later. Here's her smile, and here's her pucker. It's not perfect, but it's better. The frequency of treatment, in short, what I'll say about this is it really depends on where people are coming from and if they're coming to see me in person or if we're seeing each other on Skype, for example. So this is done on a very, very individual basis. In general, the duration of treatment is 18 months to 3 years, which is a very long time, but very well worth it. It takes a long time to learn to coordinate these muscles. We estimate that 90% of the treatment is actually completed by the person on their own at home, and that makes it a much more cost-effective program. We do use Botox with people who have synkinesis. It is injected only in the key areas of synkinesis, so you have to be very selective, because even if there's synkinesis in the smile muscle when you pucker, if you put Botox there, then you won't be able to smile. So we're very, very meticulous about where the Botox goes to get a good result. What the Botox does is it suppresses the motion in the muscles, and it allows for increased excursion or movement by reducing the abnormal pull. So for example, if we put Botox here in the platysma muscle, it won't pull down as hard, and it will allow the upper part of the face to pull up more easily. And we find that it improves in learning the new motor control and coordination patterns. And here's a person who's getting ready at our clinic for Botox, and I actually put marks. You can see the marks here on her face, and I make a diagram of where the injection sites go, and I send them over to her, with her to the doctor who's going to be doing the Botox. I videotape and photograph patients on an ongoing basis. We find in clinic that they improve 1 to 2 grades on the House-Brackman scale, and that's a scale that runs from a grade 6, which means a complete paralysis, to a grade 1, which means a normal face. We find that, for example, people who start off at a grade 4 or 5 can get up to a grade 3, but I will tell you in all honesty that nobody that I work with gets back to a completely normal face. There are residuals after nerve damage. We also find that gains that are acquired during the treatment process are retained even after the person stops the program. This is one of my patients, and this patient is about a year and a half after Bell's palsy, and I'm having her wrinkle her nose up, and you can see that she has synkinesis, a lot of contraction around the eye. Look at her neck. You can see she has good motion here as she's trying to snarl, but not good access to it, right? You can see the corner of her mouth is pulling back. This is 4 months later after training. She did not have Botox, but she learned how to inhibit all of this unwanted movement to get better coordination of her muscles. Here she is again at the initial evaluation. And this is her pucker, and you can see that her mouth is pulling toward the side, her eye is closing, her neck is pulling. You can see her chin dimples. So a lot of synkinesis here. And then 4 months later, she's learned how to control her movements a little bit more appropriately. It's not perfect yet, but she did very well with the program. You can still see she has some synkinesis in her platysma, but did very well with the program. This is somebody with congenital paralysis. I'm going to show you the punchline right here, but I do want to have at least a couple of minutes for questions. So this is Susan, and people always want to know what happened to her. Well, we discovered, I first saw her 5 years after her surgery, and her facial nerve probably was cut during her surgery. It was hard to determine from her operation report, and she did not really respond to the retraining program. But we have quite a wonderful network of professionals, plastic and reconstructive surgeons, other types of surgeons, eye surgeons. Dr. Azizadeh, for example, does different types of surgery for reanimation, and he's the director of the Facial Paralysis Foundation. We got Susan connected with a surgeon in her area, and she was able to have surgery that connected a muscle in her temple to the corner of her mouth. And in order to achieve this smile, she's actually biting her teeth together. And she was so pleased with the outcome and so happy with it that actually, if you look carefully, you can see there's a little line here at the bottom of the picture. Then this was a picture that was taken out of the newspaper. Her local newspaper did a story on her and her recovery. And she was very pleased with her outcome. So in summary, the facial retraining program is very patient-centered. It provides great continuity of care for people after Bell's palsy or acoustic neuroma. It's cost-effective, and it provides specific training for the unique characteristics of the facial nerve and muscles. It is the common wonder of all men how among so many millions of faces there should be none alike. Thank you all so much for your attention. I appreciate the opportunity to talk to you about this.
Thank you, Jackie, for your presentation today. We'll take just a couple questions from the audience now. One was, at what age do you start working with children? You possibly have it from birth. I don't know.
Well, that's a great question. The child has to be able to focus on retraining, and so there's a lot of cognitive stuff that has to go on. So it really depends on the child's maturity level. For girls, sometimes you can start working with them as early as 7 or 8 years old. For boys, it's typically just a little bit later than that. And those of you who have girls and boys know what I'm talking about. So it really depends on the maturity level of the child. So I look at that on an individual basis.
Okay, and just one more question. This was, as I've had facial paralysis for over 10 years now, and is it too late to help for any improvement?
It depends on how it looks. So, for example, if you have synkinesis, if you have abnormal movement that's occurring, like some of the slides that I showed, absolutely it is not too late to work on recoordinating. Even at the age I am right now, if I don't golf or play piano, I can learn how to do that if I get a good coach, a good pro, and I practice. If your face, the side of your face, is totally flaccid with zero motion and there's no activity at all, then neuromuscular retraining probably is not the best course for you. And hopefully that made sense.
Okay, great. Thanks so much, Jackie. And our time is over for today's webinar. And we hope everyone attending today has found this session informative and useful. We would ask you to please take 1 minute and respond to the brief survey that will come up as soon as this session ends. We will notify you by email of our next webinar event, and please visit our website in the meantime, facialparalysisfoundation.org, to find out more about our upcoming events. Thank you to everyone for attending.
Thank you.